Just know we're waiting for the ranking member, so. Good morning. Today we convene the fourth in a series of hearings examining prescription drugs and heroin addiction, the growing nightmare of one of America's biggest public health crises. Since our opioid hearings earlier this month, approximately 2,400 Americans have died from drug overdoses, and most of them because of opioid abuse. The size of this problem and the need for a new paradigm of treatment cannot be understated, and the process of developing legislative solutions has already started. Ranking Member DeGette and I have identified 15 areas in need of reform. One of those is the 42 CFR Part 2, which governs confidentiality protections for all substance abuse treatment records, both behavioral and physical, generated at a substance abuse treatment facility. It's well-intended but outdated, and Part 2 compromises medical care, increases the risk of dangerous and deadly adverse drug-to-drug interactions, and increases risk of relapse to addiction. My friend Congressman Tonko from New York and I have been working together to stop this medical records discrimination, and I thank him for his work. At the state level, responses to the epidemic vary. States like Indiana are responding to outbreaks of HIV and hepatitis. States on the East Coast are confronting the problem of heroin laced with fentanyl, another narcotic pain reliever 100 times as powerful as morphine. Some states, mostly in the South, are burdened with the highest prescribing rates of opioid pain relievers, rates that are tenfold the rates in some other states. Also, state efforts share many similar challenges. The National Governors Association said states need accurate and timely information at their fingertips concerning the incidence and scope of the problem in order to develop an effective response. States have no choice but to use incomplete and outdated data to identify areas on which to concentrate their efforts given their limited resources. Some states operate prescription drug monitoring programs, but these systems may not be easy to use. In Massachusetts, I believe it takes doctors 11 steps to use the program, which makes it difficult to encourage a high degree of participation. State systems are not necessarily connected to the systems of neighboring states, enabling abusers to doctor shop across borders since their actions are not tracked. Further, the data on these systems can sometimes be several weeks old, escalating the risk for errors from inaccurate data. Overdose prevention remains a key aim of any meaningful state strategy, yet states have adopted different approaches to address it. Some provide liability protection for individuals who act in good faith to provide medical assistance to others in the event of an overdose, or expand access to the life-saving drug naloxone, or use public education on the proper disposal of prescription drugs that are vulnerable to misuse. States also differ on availability and financing of medication-assisted treatments. Opioid maintenance is a bridge for those with addiction disorders to cross over in the recovery process, and we support that. Full recovery is complete abstinence, and medication-assisted treatment is valuable, but it must be coupled with proven psychosocial therapies and other wraparound services to support the person traversing this difficult road to help with long-term sustained recovery. Today, we want to hear from the states about best practice models, problems that they've encountered, and how states have addressed this problem. We also seek absolutely candid and honest input from each of our witnesses. Please tell us where there are problems, and please tell us where there are successes with any federal programs or policies. We will hear from representatives of Indiana, Massachusetts, Missouri, and Colorado state governments, a sampling of the 50-plus separate efforts being pursued by U.S. states and territories to counter opioid abuse. We are honored to have our witnesses join us this morning. We thank you for appearing today and look forward to hearing your testimony. And I'm purposely cutting this short so we can keep this moving. Okay. I recognize Ms. DeGette for 5 minutes.
Thank you very much, Mr. Chairman. I've been asking you to have a hearing so we can hear from the states, and I'm glad that the states are here. I think it's important because much of the work that the states are doing, or much of the work in this area, is happening in the states. I'm particularly glad that Dr. Walk is here from my home state of Colorado. I'm eager to hear about what's happening in Colorado, particularly the positive developments in reducing prescribing rates and illicit use of opioid painkillers. It's clear that if we wish to reduce the problem of opioid dependency in our communities, we also have to address the issue of overprescribing. Last year, the CDC released a report on the correlation between opioid prescribing rates and drug overdose rates. CDC Director Tom Frieden stated, quote, "Overdose rates are higher when these drugs are prescribed more frequently. States and practices where prescribing rates are highest need to take a particularly hard look at ways to reduce the inappropriate prescription of these dangerous drugs." Colorado has taken a number of important steps to address the opioid epidemic at its source. In September 2013, statewide leadership established by the Colorado Consortium on Prescription Drug Abuse Preventions, its goal is to reduce the misuse of prescription drugs through physician training and education, public outreach, and safe disposal. The goal of the coalition is also to prevent 92,000 Coloradoans from misusing opioids by 2016, and I'm sure we can get a good progress report on that from Dr. Walk. I know that Colorado has seen the rate of non-medical use of opioid painkillers fall already as a result of its work, and I'm hoping we can hear about some of these best practices and lessons learned in this process. I'm also eager to hear about how the other states here today are working to monitor prescribing rates and reduce the number of opioid painkiller prescriptions. Experts tell us that the state prescription drug monitoring programs, or PDMPs, are an integral part of the solution to overprescribing. PDMPs can facilitate better clinical decision-making by prescribers, reduce doctor shopping, and help physicians refer individuals for addiction treatment. I'm interested to hear about the efforts that the states are undertaking to make PDMPs a more effective tool. For example, again, In Colorado, we were able to double our PDMP utilization rate from 41% to 84% in just 1 year. Massachusetts also has high provider participation rates. I'd like to know how we were able to achieve such great results in such a short time. Finally, I'm interested to know more about the innovative efforts that states are undertaking on the treatment side of the equation. For instance, Missouri has made medication-assisted treatment available through all its state behavioral health organizations. The state does not contract with organizations that do not provide MATs. This is an important step to ensure that patients have access to the full evidence-based care that they need. Colorado is also taking steps to improve treatment for substance abuse disorders by integrating behavioral and primary care services in the state Medicaid program. This is an ambitious goal of integrating 80% of the primary care practices with behavioral health services, including emergency departments, clinics, and private practices. I look forward to hearing more about this initiative and to similar efforts that are taking place in Massachusetts. So the states before us have made some impressive efforts to address this public health concern, but I want to caution that a lot more work needs to be done. Even before the opioid epidemic began, our infrastructure for treating substance abuse disorders in this country was remarkably inadequate to deal with the prevalence of the disease of addiction. Given the history of neglect and underinvestment in substance abuse, it is no wonder it's no wonder that the opioid epidemic resulted in a public health crisis. There's just one last thing I want to talk about, Mr. Chairman. We had a fellow show up just in the audience at our last hearing, Don Flattery. And Don came as a citizen because he lost his son Kevin to an opioid overdose last Labor Day. And when you hear about his son Kevin, and when you hear about what this family went through, it's just heartbreaking. It's heartbreaking. I know all of our hearts go out to their family. They dedicated an immense amount of time and resources to getting the best treatment for Kevin, but they couldn't find access to the resources and quality treatment that they needed. I really want to thank Don for sharing his story with us and for providing the committee with valuable insight into the problem. I'm hoping we can hear from others like Don about the day-to-day challenges they face. Don wrote us a letter which talked about what's happened with his family, and I'd ask unanimous consent to put that in the record, Mr.
Well,
Chairman.
I agree, and because I read the letter too, it's powerful.
Yeah, thank you. And thanks again for holding this hearing, and I'll yield back.
I just want to know, too, I appreciate your request for doing this on a state level. I also want to acknowledge that I received a letter from you and Mr. Pallone on other suggestions for the committee. We do a lot of cooperative work together, and although that'll never make the news, that members of Congress do work together on both sides, I wanted to publicly acknowledge my gratitude for on that. Now, I don't know if there's any members on this side who want to make an opening statement, but I would like to give an opportunity to our colleagues from Indiana to introduce the witness from Indiana. Dr. Bouchon, are you going first, or is Ms. Brooks going first? Dr. Bouchon, you recognize first.
Thank you, Mr. Chairman. Today I have the pleasure of introducing Indiana's State Health Commissioner, Dr. Jerome Adams. Through extensive work as a researcher as well as a policy leader, Dr. Adams brings a vast breadth of knowledge and experience to both the current opioid abuse epidemic in our state and to the witness panel as we continue to work to curb the opioid abuse epidemic occurring throughout the country. Parts of Indiana have recently seen HIV outbreaks as a direct result from this epidemic, presenting Dr. Adams with a unique challenge and a unique perspective on the current crisis. His expertise will undoubtedly be valuable to this committee. Dr. Adams, thank you for appearing before us today, and I look forward to your testimony, and I yield to Congresswoman Brooks from Indiana.
Thank you, Dr. Bouchon. I want to thank the chairman for holding, once again, this important hearing and to hear from witnesses who are battling this in our states. I want to extend a special welcome to Dr. Jerome Adams, my friend and constituent. It's wonderful for you to be here, and in fact, his first day on the job, we were in an emergency meeting in Indianapolis focused on Ebola. And so here we are, fast forward just a few months, and I believe with your background, not only as a physician from IU Medical School, but an anesthesiologist at Ball Memorial Hospital, that you do have the right kind of experience and background to help lead the State Health Department at this time. And as of May 18th, there have been 158 identified cases of HIV in Scott County, and that number has gone up from the time we last had a hearing, and we're asking the CDC about Scott County. And so we know that you and your team, many of whom are with you today, have done an amazing job of curbing the HIV epidemic and slowing its growth, and we look forward to hearing your testimony today. Thank you for being here.
Gentleman
Yield
yields
back.
back. All right, I recognize Mr. Pallone for 5 minutes.
Thank you, Mr. Chairman. And I want to thank you and Mr. Gett for the hearing and for your due diligence in investigating the opioid abuse epidemic. I'm glad this subcommittee is devoting significant attention to this issue because, like all of the members here today, I'm concerned about what's happening in my state. A New Jersey state official recently reported that more than 6,000 people in New Jersey have died from overdoses since 2004. He also reported that more teens are dying from drug overdoses in New Jersey than car accidents. Today we're hearing from state health officials about ongoing efforts within their agencies to combat this epidemic, and I know you all are dealing with many aspects of this issue, from reducing opioid prescribing rates to increasing access to treatment to programs. And I look forward to hearing about the work you're doing, and I hope we can all learn from each other. I also want to hear from all the witnesses today about how we as the federal government can help fight this epidemic. We heard earlier this month from a number of federal agencies about their work, but I want to make sure we're supporting the states in their efforts to address the epidemic. We've heard repeatedly throughout this series of hearings that significant barriers to treatment for substance use disorders still exist. For example, SAMHSA's 2013 National Survey on Drug Abuse and Health found that nearly 40% of individuals who make an effort to seek treatment were unable to get treatment due to lack of health coverage and the prohibitive cost of treatment. Another 8% reported that they had health coverage, but it did not cover the cost of treatment. And with the passage of the Affordable Care Act, approximately 16.4 million Americans have gained health insurance coverage, and insurance companies are now required to provide treatment for substance abuse disorders and cover it just as they would cover treatment for any other chronic disease. But we still need to understand where barriers to treatment remain, and we should work on making sure those who want to access treatment are able to do so. I also want to hear from all of our witnesses today about how Medicaid expansion, or in Missouri's case, a failure to expand Medicaid, has had an impact on treatment for substance abuse disorders. I know Massachusetts and Colorado both signed Medicaid expansions into law in 2013, and Indiana expanded Medicaid earlier this year. So I'm interested to hear from all three of your states about how Medicaid expansion has improved access to behavioral health services. And I want to hear from Missouri how Medicaid expansion could help those seeking access to behavioral health services and what challenges you face by not expanding the program. So thanks again. I would like now to yield the rest of my time to Representative Kennedy.
Thank you. I'd like to thank the ranking member. I'd also like to thank the chairman of the committee for calling these extraordinary series of hearings. They've been, I think, extremely enlightening and shining a light on an incredible epidemic our country is facing. To the witnesses today, thank you so much for being here to discuss the state's efforts to combat opiate abuse. In my mind, we are here for one reason, and to learn from you about what has worked on the ground in your states and how we can try to support those efforts at a federal level in any way possible. Few in my home state have been spared the tragic consequences of the ongoing opioid epidemic. Last year, there were more than 1,000 deaths in our Commonwealth, spanning wealthy and low-income communities alike, areas rural and urban, faces young and old. Dr. Burrell has been on the front lines of this battle for long before she was appointed to the Public Health Commission earlier this year. But in her new role, she is focused on ensuring treatment options are available to all of our citizens, regardless of income. It's my honor to welcome her today to Washington, and I look forward to hearing your testimony. One issue I hope to hear from all of you today is a little bit about one of the issues we have been wrestling with in Massachusetts, which is the rising cost of Narcan. At a time when our country needs every tool at its disposal in this fight, the price of life-saving treatment continues to skyrocket. Last month in Needham, Massachusetts, the cost per dose rose to $66.89, up from $19.56 last June. Now, Narcan is by no means an answer to this epidemic. It is a stopgap, not a solution. But it does save lives. It allows us to get individuals suffering from crippling addiction into treatment. It helps minimize the number of parents, brothers, sisters, and children with loved ones who are taken far too soon. So I'd be interested to hear from our witnesses about any price spikes that you've seen at home, how those have impacted response efforts, and how the federal government can help ensure that no one's life is lost because a municipality simply can't afford a drug. Another area that I'd like to get some insight on is the effectiveness of prescription drug monitoring programs. I represent a district in Massachusetts that borders Rhode Island, and it's become clear to me that the lack of communication across state lines is leaving a gap in how we tackle prescription drugs. To that end, I helped co-sponsor the National All Schedules Prescription Electronic Reporting Act with Congressman Whitfield in an effort to better support state PDMPs, particularly where interoperability is concerned. Drs. Adams, Burrell, Wolk, I hope you will expand a little bit more on the role of PDMPs have played in your state's efforts to date. Dr. Stringer, I'd love if you would be able to touch a little bit about your plans, or your state's plans to develop a PDMP. Tackling an epidemic of this scope requires partners across the local, state, and federal levels. To that end, we are all deeply grateful for your presence here today. Look forward to supporting you any way we can. Thank you, and I yield back.
Gentleman yields back. I would now like to introduce the witnesses on the panel for today's hearing. You've already heard about Dr. Jerome Adams, the Health Commissioner of the Indiana State Department of Health. Welcome. Dr. Monica Barrow, the Commissioner of the Massachusetts Department of Health. Dr. Larry Wolk, the Executive Director and Chief Medical Officer at the Colorado Department of Public Health and Environment. And Mr. Mark Stringer, the Director of the Division of Behavioral Health at the Missouri Department of Mental Health. I'd now like to swear in the witnesses. You're all aware that the committee is holding an investigative hearing, and when doing so has the practice of taking testimony under oath. Do any of you have any objections to testifying under oath? All the witnesses answer negative. The chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do any of you desire to be advised by counsel today? All the witnesses indicate no. In that case, if you all please rise and raise your right hand, I'll swear you in. Do you swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth? I do. Thank you. All of the witnesses have answered in the affirmative. You are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. You may now each give a 5-minute summary of your written statement, and please try to, on the 5 minutes, you'll need to press the button so the green light's on and pull the microphone fairly close to you. Thank you. Dr. Adams, you're recognized for 5 minutes.
Thank you very much. My name is Jerome Adams. I'm the Indiana State Health Commissioner. I'm a physician anesthesiologist, and I'm the brother of an addict. On behalf of Governor Mike Pence and the people of Indiana, it's my honor to be here today. In rural Scott County, we're dealing with the largest injection drug use-related HIV outbreak in decades, with what CDC Director Tom Frieden described as a higher incidence of HIV than any country in sub-Saharan Africa. In an area that had 3 total cases of HIV over the prior 4 years, we, as of today, have 160 positives, with 95% related to injection drug use, and a hepatitis C co-infection rate of 88%. At the root of this outbreak is our country's prescription opioid crisis. The crisis is multifactorial, but I think it's helpful to separate it into 3 distinct problem and solution areas. Number 1, we need to stop the flow of opioids into communities. Number 2, we need to deal with the personal and public health consequences of communities with overflow of both opioids and people engaging in high-risk activities. And number 3, we need to create an outlet for those seeking recovery from substance use disorder. In terms of stopping the flow, in Indiana, we witnessed a 10% decrease in prescriptions since we implemented new opioid prescribing rules in 2012, but we still have work to do. We need an aggressive education and prevention strategy starting in childhood. In addition to promoting the dangers of prescription drug misuse, we need better prescription drug monitoring programs with required reporting from the VA and federal methadone treatment centers, higher thresholds for new FDA approvals of opioids, and safety and efficacy reviews of previously approved opioids based on recent data. Policy should further promote pharmacy and community opioid take-back programs and require opioid manufacturers to facilitate these endeavors. And we should revisit both pain as the 5th vital sign and the pain component of patient satisfaction as a consideration for physician and hospital reimbursement. Our focus needs to be on functionality and outcomes and not simply on stopping pain with pills. Regarding the consequences of opioid overflow, we've seen not just an HIV epidemic, but also regional epidemics of hepatitis, overdose deaths, unsustainable levels of incarceration, and community hopelessness. Our comprehensive approach in Scott County includes increased HIV and hepatitis testing and immediate treatment referral, locally based harm reduction strategies, immunizations, healthcare coverage, job training, and an outreach campaign targeting drug users and those involved in the commercial sex trade. On a state level, we formed a neonatal abstinence syndrome committee and recently made naloxone available for first responders and friends or family members of those at risk. As Governor Pence said when he signed our naloxone bill, bills like this are about saving lives. Thanks to Governor Pence fighting hard to receive the only federal waiver of its kind, and to Representative Pallone's point, we can further address the needs of those with substance use disorder, including healthcare coverage and access, the two are not equal, and job training via our Healthy Indiana plan. If people don't have hope, they will increasingly turn to and stay on drugs, a painful lesson we've learned from Scott County. Fortunately, over 225,000 Hoosiers have more hope now thanks to HIP 2.0. Lastly, in terms of creating an outlet, we must provide options for those seeking recovery services. A national campaign could reduce the stigma of substance use disorder and HIV so people aren't ashamed to seek services, and could help reframe addiction from that of a moral failure to that of a medical disorder that requires a lifetime of attention. Lack of recovery reflects a lack of enlightenment on society's part as much as it reflects a lack of earnestness on the sufferer's part. Regarding recovery in Scott County, we found a severe and unmet need for access to appropriate substance use disorder treatment, and we've accordingly worked to increase beds and outpatient services. When incarcerated, sufferers also should have access to mental health and addiction treatment with linkages to these services upon release. Such programs exist in Indiana, but are often only found in the most well-resourced communities. And we must educate communities and the public about medication-assisted treatment as an important component of the recovery safety net. Recently enacted legislation in Indiana allows the establishment of additional methadone clinics in our state, and the criminal justice system at the county level is increasingly offering Vivitrol for inmates upon release or as an option during drug court diversion programs. Our situation in Indiana, in closing, may be unprecedented in many ways, but in many others it illustrates problems faced throughout our country. There's much we do, but I am confident that we can succeed. If we focus on education, patient-centered care, and community and patient empowerment, I am confident we can successfully combat the scourge of opioid abuse. Mr. Chairman, thank you for your time, and I look forward to the opportunity to answer your questions.
Thank you very much, Doctor. And now, Dr. Barrow, you're recognized for 5 minutes.
Thank you, Chairman Murphy, Ranking Member DeJette, and the members of the committee. Thank you for welcoming us here today and for the opportunity to provide this testimony on this incredibly pressing issue today. My name is Dr. Monica Burrell, and I'm proud to have been appointed to serve the Commonwealth of Massachusetts and Governor Baker as its Commissioner of Public Health. I'm honored to be here representing one of the nation's oldest public health departments, one that traces its roots back to Commissioner Paul Revere, and one that has continually led the way in public health across the country. Yes, we can talk more about that later. As a front...
He alerted people with lanterns. I'm aware of that. So.
He gave out information on cholera throughout the Commonwealth. As a frontline physician and as a former chief medical officer at Boston Healthcare for the Homeless program, the largest of its kind in the nation, I've seen firsthand the rising tide of an opiate epidemic that is overwhelming communities. We have watched our family and friends die on our streets, driven by a lethal cocktail of trauma and underlying behavioral health issues. This is not something we as a society should accept as the norm. This epidemic will be far from easy to tackle, but this challenge is precisely what drew me here to work with you and our providers, our community leaders. To that end, we are already hard at work in Massachusetts and throughout the Baker administration, redoubling our efforts to identify, triage, address, and treat the opiate epidemic. First, to identify the problem. Like so many states across the nation, Massachusetts is facing a growing epidemic of opiate addiction and overdose deaths. In 2013, there were 967 unintentional opiate deaths, compared to 371 motor vehicle-related injury deaths. That's 2.5 times as many people dying from opioid use as from motor vehicle-related injuries. And behind those 967 deaths are over 2,000 hospital stays and more than 4,500 emergency room visits, and of course, unquantifiable human suffering. And in 2014, we have projected estimations of over 1,000 people dying of an opioid-related overdose. This is a 51% increase from 2012. We will fail in our efforts to address this crisis if we do not fully involve partners from all sectors. That includes law enforcement, public health, healthcare institutions, families, schools, and you, our elected officials. Governor Baker prioritized the opiate epidemic early in his new administration. In February, Governor Baker appointed 18 individuals to serve on his opioid working group. The group represents the many different perspectives that are important to this work and was charged with developing tangible recommendations. The working group has held listening sessions across the Commonwealth, hearing from over 1,100 individuals and receiving hundreds of recommendations and emails. No matter which of the lens these individuals look at this epidemic, one thing is obvious, that opioids are impacting every city and town in the Commonwealth. People speak again and again about the wish to have early prevention and increased access to treatment. Our success getting to the underlying health issues and social determinants that are driving this epidemic, trauma and undiagnosed behavioral health issues, chief among those, will directly correlate with our ability to successfully leverage data and to measure results. This data will allow us over time to effectively target key populations and hotspot, if you will, to better understand the impact of our collective efforts and how to use our limited resources better. Utilization of data to combat the opioid crisis has a long way to go. For example, currently at our Department of Public Health, we have more than 300 different internal data systems that have developed by individual programs and use a variety of different formats. They're managed by different staff and reside on different servers that don't talk to each other. However, this problem is not unique to Massachusetts, and across the country, public health needs to double down on data and on interoperable, secure IT solutions, such as data warehousing, to create better linkages between our siloed data sets. As a frontline clinician, I have experienced firsthand the real roadblocks to helping patients access care. In the area of access, particularly with regards to downstream post-detox care, individuals have had a lot of trouble with both residential and outpatient medication treatment service availability. In capacity, statewide bed capacity, the kinds of bed types available and how to access them are not well known. Services for mothers and fathers in recovery who are attempting to reclaim their lives while trying to take care of their children needs improvement. Individuals suffering from addiction need better access to childcare, stable housing, and employment opportunities, as well as access to timely treatment. We need more early interventions in schools, and perhaps most important, this issue of stigma. What this hearing alone represents is an important step towards societal recovery. We need to talk about this disease. This is a chronic disease, and as a community and a nation, we will treat it and we will find pathways to recovery together by first speaking of it as a chronic disease. From the bedsides to the halls of bureaucracy, addressing this opioid crisis requires taking action across the spectrum of prevention, intervention, treatment, and recovery support. At DPH, we're proud of the progress we've made in areas such as access to naloxone kits, with the cities of Quincy and Gloucester being some of the first communities in the nation to arm themselves with naloxone. Beyond saving lives, this measure has changed attitudes, with police no longer arresting their way out of this epidemic, but looking towards solutions.
I'll need you to wrap up if you could.
Sure. And as a medical community, we know that 20% of pain relievers for non-medical use are coming directly from clinicians. So we as clinicians must shift our expectations and practices that opiates are not the first line of defense. However, as our national data sets demonstrate, more than 80% of lethal painkillers come from non-clinicians. And so again, this highlights the elemental truth of working across partnerships. And I look forward to answering any further questions you have. Thank you.
Thank you very much. Dr. Wolk, recognized for 5 minutes.
Thank you, Chairman Murphy, Ranking Member DeGette, and members of the subcommittee for the opportunity to provide testimony to you today about our efforts to address the opioid epidemic in Colorado. In 2012, we had the troubling distinction of ranking second nationally for self-reported non-medical use of prescription drugs. More than 250,000 Coloradans misused prescription drugs, and consequent deaths related to misuse nearly quadrupled between 2000 and 2011. Drug overdose remains the leading cause of injury death in Colorado, and almost 11% of Coloradans aged 18 to 25 still engage in non-medical use of prescription drugs. In the last 5 years, the number of heroin users in Colorado has also doubled, and we are challenged with concerns that existing treatment capacity is not meeting a rising demand, as treatment admissions for heroin and prescription opioid abuse increased 128% between 2007 and 2014. However, recent data suggests that we are heading in a better direction. 2013 data released shows that our rate on non-medical use has decreased from 6% to nearly 5%, which represents 39,000 fewer Coloradans who misused prescription drugs. Additionally, the Colorado youth use rate is decreasing and is now below the national average. Since 2012, catalyzed by Governor Hickenlooper's leadership as a co-chair of the NGA's Policy Academy for Reducing Prescription Drug Abuse, we are currently implementing a coordinated approach, setting as our goal to prevent 92,000 Coloradans from engaging in non-medical use of prescription pain medications through the adoption of our Colorado Plan to Reduce Prescription Drug Abuse. This commitment represents a reduction from 6% to 3.5% of Coloradans who self-report non-medical use of prescription drugs, focusing on 7 key areas: improved surveillance of prescription drug misuse data, strengthening the Colorado PDMP, educating prescribers and providers, increasing safe disposal, increasing public awareness, enhancing access to evidence-based effective treatment, and expanding access to the overdose reversal drug naloxone. To monitor and coordinate progress, state-level leadership created the Colorado Consortium for Prescription Drug Abuse Prevention. The consortium provides a statewide, interagency, inter-university framework designed to facilitate the collaboration and implementation of the strategic plan and is comprised of 7 work groups. For one, the Data and Research Work Group of the consortium has worked to map out all sources of data related to prescription drug use, misuse, and overdose in the state. Second, the PDMP work group has worked over the past 2 years to enhance our state's PDMP as an effective public health tool. As of July 2014, our PDMP utilization rate was 41%, and in April 2015, that rate more than doubled, reaching 85%. How did we accomplish this dramatic improvement? We recently implemented push notices to both prescribers and pharmacists when patients visit a certain number of prescribers and pharmacies to obtain a controlled substance. We require PDMP registration for pharmacists and DEA-registered prescribers, but we allow prescribers and pharmacists to assign and register delegates in their office, because they're often busy, so that those delegates can check the PDMP. We've also enhanced the PDMP interface and moved to a daily upload of data so that it's constantly refreshed. The Provider Education Work Group focuses on issues relating to improving the education and training of healthcare professionals through a jointly developed policy, a policy that has since been adopted by the dental, medical, nursing, pharmacy, optometry, and podiatry boards in Colorado. It's the first joint policy of its type adopted by multiple regulatory boards. As of October 2014, over 1,300 prescribers had completed the training developed from this policy, and 87% indicated that they intended to change their practice as a result. We were encouraged because the CDC Morbidity and Mortality Report recently ranked Colorado 40th nationally for prescribing rates of opioids, 50th being the lowest rate of prescribing. The Safe Disposal Work Group focuses on issues relating to safe storage and disposal of prescription medications with the potential for misuse, abuse, or diversion, knowing that more than 70% of those who abuse obtain them from the unused supplies of family and friends. This work group developed guidelines and outreach efforts and expanded the number of safe disposal sites throughout the state. By next year, we have plans to provide drop boxes in every county in the state. Public Awareness Group has developed a new statewide advertising and public outreach campaign called Take Meds Seriously. Our consortium's treatment work group has focused on identifying gaps in the need for medication-assisted treatment, and our naloxone work group focuses on increasing awareness of and access to naloxone, making clinical, organizational, and public policy recommendations to achieve this goal. I thank you for the opportunity. I see that I'm out of time, and thank you.
Thank you, Dr. Wilk. Mr. Stringer, you're recognized for 5 minutes.
Chairman Murphy, Ranking Member DeGette, and members of the subcommittee, my name is Mark Stringer, and I'm the Director of the Division of Behavioral Health in the Missouri Department of Mental Health. I also have the privilege of serving as President of the Board of the National Association of State Alcohol and Drug Abuse Directors, or NASDAD. It's truly an honor to offer remarks this morning about what Missouri is doing regarding the opioid problem in particular and addiction in general. If there's a theme running through our messages this morning, it is, and I believe one of the most important ones, is that access to treatment and recovery services is essential to addressing this problem. On this very day in Missouri, nearly 3,000 people are on waiting lists for substance use disorder treatment services. That equates to about 43,000 Missourians waiting for help during the course of a year. What's truly sad about this is that often a person seeks treatment after some kind of a life-altering event, a run-in with the law, a problem at work, some type of illness, an overdose. So every name on a waiting list is a potential tragedy for an individual, a family, and a community. In order to be successful, services must be accessible. They've got to be individually tailored, evidence-based, and they must include recovery supports. One thing I know with certainty, after 30 years in this field, is that treatment cannot be effective, and treatment cannot possibly work if you can't get access to it when you need it. So I'll give you some just quick information about my state of Missouri. We estimate that about 400,000 Missourians have substance use disorders. Last year, 43,000 actually received treatment services through the publicly funded system. With regard to opioids, Missouri saw a 124% increase in treatment admissions related to prescription drugs from 2007 to 2012, and a 125% increase in admissions related to heroin. We lose about 200 people to heroin deaths each year, most of them in eastern Missouri, including St. Louis. Here are some steps we're taking to deal with the problem. We developed a statewide plan for coordinated treatment and recovery services, and we partner with providers to ensure that services are high quality and evidence-based. One tool for promoting quality is our contracting authority, building in certain requirements that providers must follow as a condition of receiving state funds. We perform on-site certification reviews to assure that providers are adhering to standards of care that are set by the state. As an example, we use these tools to require that all addiction treatment providers in Missouri, who are, again, contracted with the state, make medication-assisted treatment available, either directly or by referral. This took time, resources, and education, and it's a work in progress, but it's the right step for Missouri. We've also worked hard to leverage SAMHSA's Access to Recovery Program, or ATR, to build a statewide system of recovery services. Prevention is critical. Our state has a strategic plan for prevention with a focus on prescription drug abuse. And we've partnered with a group, just as an example, in a college setting, we have a group called Partners in Prevention. That's a coalition of 21 college campuses located throughout Missouri, which is working specifically on prescription drug abuse among college students. This effort has made a difference. From 2013 to 2014, we've seen a 10% decrease in the misuse of prescription drugs among college students. There are other initiatives in my written testimony, but I'll now turn to a few recommendations. I recommend that all federal initiatives specifically include involvement of state substance abuse agencies, like mine, given their expertise and authority over the addiction prevention, treatment, and recovery systems. And I particularly want to recognize the Director of the Office of National Drug Control Policy, Michael Botticelli, for his efforts to coordinate drug policy across federal government and to keep states informed and engaged. Second, I recommend strong support for the Substance Abuse Prevention and Treatment Block Grant, a vital part of the public safety net for treatment that also provides an average of 70% of state substance abuse agencies' funding for primary prevention. Third, I support specific initiatives to increase the availability of all FDA-approved medications for substance use disorders, and I applaud the administration's proposed $25 million for states to expand opioid treatment services where medication-assisted treatment is an allowable use of funding. Fourth, I recommend specific resources to help states and localities purchase naloxone. This would have an immediate life-saving impact, and I appreciate the administration's proposal to provide $12 million within SAMHSA for overdose reversal and prevention activities. I certainly support mandatory prescriber education and training on substance use disorders. And finally, I encourage Congress and the administration to continue to work with state-based groups heavily involved in this issue, including groups like the National Association of State Alcohol and Drug Abuse Directors, the Association of State and Territorial Health Officers, but also our parent group, the National Governors Association, which has provided critical leadership in this area. Thank you for this opportunity to testify, and I look forward to answering questions.
I thank all the panelists. I'll now recognize myself for 5 minutes of questions. Mr. Stringer, your office sits within Missouri's Department of Mental Health. And in the course of your work, have you found that federal policies, including those affecting the ways in which certain treatment options are funded, have hampered any mechanism to treat individuals with co-occurring substance abuse and mental health disorders? And if so, what can be done? What do you suggest we do to correct that?
Mr. Chairman, I'd be hard. I'm not sure it's a policy issue. I'll try to answer that yes or no. Yes, there are some things that get in the way of treating people with co-occurring disorders. Primarily has to do with funding streams, how funding comes to the states, what the limitations are, and how those funds are spent. We have been successful in Missouri, I think, at braiding funds for people with co-occurring disorders, and so we treat some. So what we've done is really enhance our substance use disorder programs to include some mental health services. We've enhanced our community mental health services to include substance use disorder services. So we've been able to do that with the flexibility that's already there.
I ask that because we've had other witnesses say they would like to have let the federal government merge some of those funds. They can treat both. I'd like to open this question up to all of you. I made some comments in my opening statement regarding the 42 CFR and some concerns it has with interfering with doctors' ability to provide safe and effective treatment for patients. I don't know if any of you have reports in your state, but let me elaborate on this. A basic quality measure of good health care is medication reconciliation, as you are aware, which means assessing and documenting all the medications someone may be taking, which would include buprenorphine, Vivitrol, or all these other ones. But as a result of the 42 CFR Part 2, a doctor's ability to complete these medication reconciliations is very compromised. As I said, Mr. Tonk and I are working on this. So a patient may be getting Suboxone from an addiction medication physician, but fails to inform, this person may fail to inform the family physician, who may recommend another things, or you can have someone on Vivitrol and doesn't tell the physician, and next thing you know, they get a pain medication, an opiate, and now you've got someone who either has a risk of death or you increase a risk for relapse. And I wonder if any of you can comment on any suggestions of this. Dr. Wolk, you're nodding your head. You have some comments on that?
Thank you, Mr. Chair. Prior to assuming this role 2 years ago, I was the CEO for the state's Health Information Exchange, CORIO. And you highlight a very big obstacle when it comes to exchanging and making available clinical information to all providers involved in a patient's care. If a health information exchange is going to work with regard to reducing duplication, improving quality, and reducing cost, the healthcare provider has to have access to all of the patient's information, whether it's physical, mental health, or substance abuse related. So,
but we do have barriers that mental health therapy notes don't get into those things, which is okay. Well, that's a good point. Oh, I want to follow up with the word. Dr. Adams, I want to catch you before my time's out here. The diversion of buprenorphine for illicit non-medical use is a significant problem, and this is part of the reason why the opioid epidemic is spreading. According to the Drug Enforcement Administration, buprenorphine is the third most seized prescription opiate by law enforcement. And so is the diversion of buprenorphine a significant problem in your state, and how are you handling that?
It is a significant problem in parts of our state, and that's why we need to have a larger conversation about medication-assisted treatment and what it can and cannot do. Vivitrol, for instance, is a wonderful drug for a very small subset of the population. Methadone, we need to separate the discussion between methadone for chronic pain versus methadone for substance abuse treatment and medication-assisted therapy. And so, again, I would promote educational campaigns both for the public, for policymakers, and for physicians, quite frankly, in terms of what can and can't be accomplished. And Suboxone is a great drug, again, for a certain subset of a population when done right, but we found when done wrong, diversion can occur, and that's a concern that has been brought up by particularly our correctional facilities, where people say they can easily sneak it in to the correctional facilities.
I appreciate that. And I just, my time's almost up, but this is the kind of thing we're going to want you each to comment on. In addition, we made reference before to Don Flattery, a letter to us, and he brings up an important point here that opiate pain relievers, or OPRs, can worsen chronic pain over time. And that's another area, it seems to me, as you're recommending, we need to do much more in education, mandatory education of physicians and prescribers on that. But so keep that thought in mind. We're going to want some input on that, too. I now recognize.
Mr. Chairman, and one thing you can do concretely is you can have the VA and you can have federal methadone programs report to prescription drug monitoring programs. You all can do that, and that will help get information out to the physicians.
Excellent. Thank you. Thank you.
Well,
Mr. Gett, 5 minutes.
thank you. This sort of follows up on your line of questioning, Mr. Chairman. Dr. Wilk, I wanted to talk to you about the prescription drug monitoring program a little bit and what we've done in Colorado. We passed a law in Colorado that now requires medical professionals who prescribe powerful controlled substances to sign up for an account. Is that right, Dr. Wilk?
Thank you, Representative DeGette. That is correct.
And since Colorado implemented that law, the use rate of the PDMP has doubled, going from about 40 to 85% in less than a year. Is that right?
Thank you, Representative DeGette. That is also correct.
And do you think that mandating the need to have an account with the PDMP is the key to Colorado's higher provider utilization rates? Is this something you think that other states should consider?
Thank you, Representative DeGette. I do. In addition to having the allowance for a delegate in the prescriber's office, because mandated participation, but then actual participation is enhanced by allowing that delegate to be assigned to work on behalf of the provider.
Okay. And I understand also that key medical boards within the state came together, as we do in Colorado, because that's the way we are, to create prescribing guidelines for opioid therapies. Can you talk about how this guidance is helping to guide Colorado doctors and dentists in their prescribing practices?
Thank you, Representative DeGette. It is a policy that was developed and then a training from that policy, and because of the universal endorsement or adoption by all of those different boards of healthcare professionals that are in a position to prescribe, we really have seen universal acceptance, high numbers of participation, and a very high number, 87%, who said they would change their practice now as a result of that training.
So when were all of these guidances, what year were they adopted?
Thank you, Representative DeGette. It's within the past 2 years.
Okay, because you had some alarming statistics in your testimony about the way opioid use was going up in Colorado, and now we seem to be bringing it down. Do you think that these new guidelines have helped towards that goal?
Thank you, Representative DeGette. I do think that they have, and we have some preliminary data coming in for 2014 that shows further stabilization, at least on the prescriptive opioids.
And Dr. Adams, I wanted to ask you, I understand that Indiana has adopted mandatory prescribing guidelines for opioid therapies. Can you talk to us about how the guidelines work and what impact that they've had on this overprescribing problem?
Well, again, we've seen a 10% drop in prescribing since we've instituted our opioid prescribing rules. And I will tell you, I was on the State Medical Association Board of Trustees when these rules were coming through. Education is paramount anytime you're trying to prescribe what doctors are and are not going to do. As far as high points, we have an overall threshold in terms of if you go over 60 pills per month or 15 milligrams per day for over 3 consecutive months, you have to abide by these rules. There's a mandatory assessment, which includes an H&P, and unfortunately, we found people were prescribing pills without actually seeing patients or doing a full exam. There are regular visits if you're prescribing. There's regular checking in with the prescription drug monitoring program, or our inspect program, up front and then at regular intervals. There is drug testing, and docs have told us over and over and over again, we need a way to prove whether or not they're taking the drugs or diverting the drugs. So drug testing is part of that. There's a daily threshold limit that if you go over 60 milligrams per day in the course of therapy, then you have to bring the patient back in for a face-to-face and consider referring them. And then there's contracts. And docs have told us those have been helpful too, in terms of establishing the relationship, the expectations, and being able to fire a patient. The best man at my wedding got sued by someone who was using because they said he kicked them out of care and abandoned them. Contracts protect doctors moving forward in terms of being able to say, I told you this, these were the expectations, you violated them, and it empowers doctors to be able to participate. But we codified those into our rules and regulations, and it has been a tremendous success.
Thank you. I just want to talk for 1 second about treatment, because I've heard that there's a shortage of doctors who can administer this MAT treatment, particularly in rural areas. So I just wanted to ask you, Mr. Stringer, very quickly to talk about Missouri. I understand Missouri requires all state behavioral organizations to offer MAT treatment to all patients with opioid disorders. Has this helped improve access for the patients?
Thank you, ma'am. It absolutely has improved access to evidence-based care. I will tell you that this has not been easy for our providers to find physicians. We had one in southwest Missouri who has since become one of our leading providers of medication-assisted treatment, but in the early days had to go through the yellow pages, physician by physician, to try to find one who was willing, number one, to work with this population, because many are not, and then secondly, who would work for the relatively low reimbursement rates that they could offer. So it was a real challenge, but absolutely it's increased access to evidence-based treatment, but we still have these waiting lists.
Thank you, Mr. Chairman.
Thank you. Mr. McKinley, recognized for 5 minutes.
Thank you, Mr. Chairman. Again, thank you for continuing this dialogue that we've now been doing for some time, 4 or 5 hearings this year, and building off what we've learned in the past. We had a couple years ago, we had a hearing in another committee with the Attorney Generals had come in and talked about one of the things that they were suggesting on drug overdose and prescription, the pill mills, so to speak, was having a national registry in real time that was available to people across state lines as a way of capturing people that are trying to beat the system. Is that something, I haven't heard any of you talk about the real-time entry data on that. Is that something, Dr. Wolk, would you, I see you nodding on that. Is that one of the things we should focus?
Thanks, Representative McKinley. Yes, we moved from periodic uploading to now daily uploading of the information, so it is real time with regard to our Colorado PDMP
Yeah, that's
registry.
just in Colorado, but if they go across the state line, that's not available as well.
Right, so I would support, I think we would be happy to morph our state PDMP into a national PDMP, so that, especially for neighboring states, I think this is a significant challenge.
Thank you. Dr. Adams, your comment back about the overprescription, maybe I'd like to get some more. You started rattling off a lot of statistics and things that you do within the Indiana to see how that works. I'd like to see that, how that we might be able to apply that in West Virginia as well, maybe across the country. So if that's not part of your testimony, if you got that separately, if you could send that, because we had this hearing just 3 weeks ago. We had 7 panelists. And all of them said, this is the #1 priority, this is the #1 priority, and all of them were giving us different priorities. And I'd like to think that Congress can walk and chew gum at the same time. But when we have from professionals giving us all 7 different directions, all 7 agencies, so we asked them to, what is the #1 thing? And they talked about prescription. They said, we're overprescribing. So in the last 3 weeks, I've talked to numbers of doctors at round tables in West Virginia, and they're concerned with it. They agree. They say, yeah, we're making addicts with what we do, but we have to have a development of trust with our patients. I got nervous about the fact that, do we want Congress to try to medicate or try to control or try to practice medicine on pain? So they're saying it's trust. How have you been able to rectify that, reconcile that in Indiana about dealing with that problem?
Well, there's no doubt, and it's obvious from our outbreak, that we've still got a lot of work to do. And I quickly want to touch on the point you brought up earlier. We could use a national registry for providers who divert on the job. That's a concern. Indiana was also one of the first was the first state to have our prescription drug monitoring program talk across state lines, and it's still a problem. Scott County, Indiana is just 20 minutes north of Louisville, but whether it's a national registry or just providing grants and funding to facilitate state PDMPs to adopt best practices that talk across state lines, the consistent thing you heard all of us say is we need better communication, we need more real-time information. As far as the trust factor, again, it's an uphill climb, but we've worked closely with our state medical association, and we got buy-in from doctors in terms of participating and other prescribers. And I think an important point my counterpoint brought up from Massachusetts was that it's not just docs. A lot of these are delegated prescribers. And the way you get around that problem is you have integration with electronic medical records.
If the more that if you get me that information.
I'd love to.
Then I want to open it up to all the panels. I'm just curious because we raised this issue last time, 3 weeks ago, and that was that the rate of deaths in America from drug overdoses is anywhere from 7 to 10 times higher than it is in Europe. And I raised that question then, and I raised it again. What are they doing right, or what are we doing wrong? Why from 30,000 feet? What's the difference? Why do we have such a problem in America compared to Europe?
Again, pain is the fifth vital sign, an overflow of opioids going into the system, a lack of education for providers, and understanding on the part of children.
So they're doing
these
a
are
better
safe.
job in Europe? That's what you said. The doctors are doing, the medical community is doing a better job in Europe?
I think there are less opioids available in general, and I'll yield to my counterpart from Massachusetts.
Oh, I'm sorry, we're going to run out of time. So if you could get back to me, please, I would appreciate the time back here. Thank you.
And the committee, we will appreciate also the further elaboration on your point about when that becomes part of the hospital satisfaction survey, and then, of course, they get additional funding, and that cycle too. Now recognize the ranking member, Mr. Pallone, for 5 minutes.
Thank you, Mr. Chairman. I wanted to mention, even before the opioid epidemic began, our infrastructure for treating substance abuse disorders in this country was shamefully inadequate, including cuts to our healthcare system through sequestration. A combination of long-term neglect, social stigma, and underinvestment by both the state and federal governments has led to a system in which only 1 in 10 Americans with alcohol or drug addiction receive any form of treatment, and of those who receive treatment, only 10% received evidence-based care. You combine this neglected behavioral health system with an epidemic of opioid overprescribing, and it's really not surprising that we're currently facing a public health crisis. So questions, I'd like to ask all the witnesses on the panel a question. Is our underinvestment in behavioral health services, including the effects of sequestration, hampering our response to the opioid epidemic? And let me combine that by saying, have you seen the effects of sequestration affect what you're doing at the state level? And are you able to keep up with the increased demand for treatment with the current level of resources dedicated to the problem? I guess I'll start with Dr. Adams and go down.
Thank you for putting me on the spot, Representative. One thing that I've always held as my own personal adage is spending more is not the same as spending wisely. And so we'll all come to you all and say we want more money. But the fact is, what we're concentrating on, and something you've heard continually, is that we need to do a better job of communicating with each other to make sure we are making the most efficient and effective use of the funds that we have available. We need to make sure we're talking with communities, make sure we're talking with nonprofits, make sure that through electronic medical records, we're getting the information that we need. Policy is always, there's always a pie that gets split up. And so do we have enough money? Again, I'd always love more money, but what I'd love most from you all is help in terms of making sure the right partners are at the table so that we can get the most out of what we're spending.
I mean, I appreciate what you're saying, but I'm saying my concern obviously is first sequestration, but even more so, you have more and more people that need treatment, and at best we're talking level funding. So, you know, if you could be a little more specific about the consequences of that, I'd appreciate it. Not that I'm taking away from what you said. Dr. Barrow?
So I want to bring us back to this point about this chronic disease model. So if we look at how we treat other diseases within the medical spectrum, when we talk about diabetes, there's multiple places to enter based on the level of severity. So you come in through the emergency room, you go to an ICU, you go to a hospital, you go to outpatient. When you are suffering with the disease of addiction, there's very few routes to enter the system. So when we talk about different funding sources, I would like our goal to be to look at it as a complete health system. Getting back to this concept about Europe, if we think about health as a whole entity and the public health starting at the community and going through the hospital system and out, we have to culturally think about, not in our fast-paced thinking about pain being gone, but pain being relieved to a certain level, thinking culturally about pain not only being relieved with pills, but other entities that are available as well. And then in addition to that, having PMP. 79% of our physicians in Massachusetts are on the PMP, but they say when we can't then use painkillers, what are our other opportunities? So there's educational opportunities there as well.
All right, but you guys don't want to seem to want to talk about money.
I do.
Let me add one more thing. Let me add one more thing. You know, SAMHSA, we understand that the SAMHSA block grant, or the Substance Abuse Prevention and Treatment Block Grant, you know, has actually been cut by 25% in the last 10 years. So, you know, maybe you want to talk about that if you don't want to talk about the other things. Go ahead.
Thank you, Representative Pallone. I'll be quick because I know you want to say something about that. Absolutely, sequestration has had an impact. We cannot keep up with the demand, number one. So any additional resources that we can get through block grant money or however else we can do this would really be appreciated, because even as an ACA state, ACA only goes so far with regard to coverages that folks can get adequate care. We received $65 million from the federal government for our innovation model, as Representative DeGette alluded to, so that patients coming to their primary care doctor can get integrated physical and behavioral health care services, including substance abuse, screening, treatment, services as well, because we're so desperate to try and address this access issue and this lack of resource issue that maybe there's something there with regard to where they get their primary care.
Thank you.
Mr. Chairman, I know we're out of time. If I could, I'd like to follow up in writing if I can. That's a great question. I very much appreciate that. I was at a women's prison in Missouri, in Vandalia, just Tuesday of this week, and I've got some stories to tell from that experience. So
We would appreciate that. Thank you very much. Now recognize Dr. Bashan for 5 minutes.
Thank you, Mr. Chairman, and this has been very insightful. Your testimony is very insightful. Dr. Burrell, I was interested in one of your things you said, that 20% of the medication that people are abusing are coming from for medical reasons, that have been prescribed for medical reasons. And one of the things we've been focusing on, of course, is, you know, I'm a physician, I was a cardiovascular surgeon before, is prescribing, you know, monitoring prescribing habits, but if 80% is coming from somewhere else, where is it coming from? 70, 80%, whatever it is. I think you said 80%.
Yes, so it's 80%, of which 70% is coming from family and friends.
Okay, that's what I figured, and it's not their particular medical use, but at the end of the day, it's been prescribed for a medical use for someone. Okay, and that's where maybe, you know, drop boxes and other initially voluntary return policies potentially could be helpful, because yeah, there are, last year, you probably know, there were enough prescriptions written that every person in the United States of America could have gotten a bottle of narcotic pain medicine. And Medicare Part D just came out and said recently that the #1 prescribed medicine under Medicare Part D, and so this goes across ages, right? It was Vicodin. And so the prescribing, I'm very interested in the prescribing programs and trying to monitor, you know, physician prescribing, and as part of that, education is, of course, important, and that's where it's not only for the people that about using it, but it's the people that are being trained to take care of patients as we speak in health, in medical schools and other areas. So that's going to be very important. Dr. Adams, in your testimony, you say an aggressive educational strategy beginning with childhood. Can Can you kind of expand a little bit on that, and what your thoughts were on that?
Well, thank you for the opportunity. And for those of you who don't know, Congressman Bouchon married up. He married an anesthesiologist. But as far as that,
That is
to
a
get that
true
one in there.
statement.
The aggressive educational campaign, quick story. I was in Scott County just a few weeks ago meeting with a 23-year-old individual who had HIV. He was in our clinic. And I said, how did you get started? He said, I had an injury as a freshman in high school, knee injury playing football. The doc prescribed me Vicodin. I kind of liked how it made me feel, so I took all the Vicodin he gave me, took some more, ran out. He said it was easy to get in the community, got more Vicodin. Finally, that wasn't doing the job. Switched to OxyContin until that wasn't doing the job. Then I started injecting. And then he switched over to heroin, and now he's a 23-year-old HIV addict. We've got to get to these people earlier, and when you talk about an aggressive strategy, it starts with recognition. We need an educational campaign to help students understand that this is a problem. I used to sneak to my friend's house when I was in high school and have a beer. They sneak to their friend's house and pop a pill. And unfortunately, 1 out of 15 people who divert a pill will ultimately go on to heroin use. 1 out of 15 of my friends who popped a beer didn't go on to get HIV. So that we need to increase the recognition of the problem. We need resilience and anti-bullying campaigns so that kids are okay saying, no, I'm not going to take a random pill out of that bowl. We need appropriate age-level education, and I was meeting with people from the state just yesterday who showed us their data, and the interventions in each age group are different. What works for a 5th grader doesn't work for a 6th grader, doesn't work for an 8th grader. There's got to be age-appropriate education and intervention. There's got to be adult and peer outlets, so hey, if someone's doing something wrong, I know who to go to, I know who to tell. And then finally, to your point, we need take-back programs. 62% of teenagers who use say the number one reason they use is because it's easy to get the medications from my parents' cabinet. It's right there. It's easier to get a pill than what it was for me to get a beer. And you can hide it and you can walk away with it. And so all that needs to be part of the campaign, and it needs to start in middle school and elementary school. Did you have a...
I got one other question I want to ask about naltrexone, because I've given that to patients in a hospital setting. And Mr. Springer, maybe you can comment on that. And I think not only the availability, but the appropriate training for people, for law enforcement people or EMTs about the fact that, like somebody pointed out, it's not a silver bullet here. There's also downsides to giving patients Narcan or naltrexone. Can you comment on that? About what type of educational stuff is also, I mean, I think, were you one of the ones that were commenting on naltrexone? Yeah. Or maybe Dr. Burrell could answer that.
Maybe I can just
Yeah.
start. I mean, and certainly, I'll tell you, when I went to...
And I'm out of time, so can you, why don't we just do this? Why don't you just, why don't we,
You want Dr. Burrell to answer?
that'd be fine.
So as part of our Narcan program, so we've handed out in Massachusetts since 2007 over 35,000 doses of Narcan, and part of that includes, to your point about education, so the individuals who are handing out the Narcan to both bystanders and law enforcement, there's a training that goes along with it, and they are also trained on rescue breaths and the importance of it being short-acting and to call 911 at the same time. And we've recorded over 5,000 reversals with that.
Yeah.
So the educational component is directly linked when we hand out our doses.
Yeah, I think that's important because, in my opinion, if someone has to give someone Narcan, they should also be calling 911, and those people probably should be transported to a medical facility. Thank you. I yield back.
Yeah, we'll want your other thoughts on it, too. We've also heard some people saying then some people have a false sense of security, thinking, oh, there's Narcan around, I can go ahead and take the risk. Ms. Tonko, you're recognized for 5 minutes.
Thank you, Mr. Chair. Mr. Stringer, earlier on in the questioning about sequestration, you had some comments that we didn't get to. Perhaps you could share those right now, please.
Yes, thank you very much, Representative. In my some written testimony, there's a 2-page thing from NASDAQ here that describes the block grant and the reduced purchasing power of the block grant over time. I will tell you just specifically with regard to sequestration, we in the states have really counted on the federal block grant to sort of be our safety net. We have some state safety net funds, but the block grant has always been stable. It hasn't grown enough to keep pace with inflation, but it's been stable. What we saw with the sequestration was that our sense of stability was shaken because we were during tough economic times at the state level, and then our block grant funds were reduced temporarily. Just this last Tuesday, I was visiting a women's program in Vandalia, Missouri, where we have a unique program going on right now where women offenders who leave that institution are started on medication-assisted treatment before they leave. So when they go home, they return to stable environments. 2 of the women that I talked to had been on medications before they returned to prison. One was a young lady who was young, attractive, smart, had 2 children, was back in prison for her 4th DWI offense. Before coming to prison, she had been on medication-assisted treatment, but because of budget cuts at the state and federal level, her medication-assisted treatment was stopped. And she returned to drinking very quickly after that, got her 4th DWI offense, and then wound up back in prison. So, you know, the stability of the block grant and I hope future increases in the block grant will really help to shore up our safety net and increase access and sustainability of treatment.
I appreciate that. And for far too long, our national infrastructure for treating substance use disorders has suffered from fragmentation, from neglect, and certainly underinvestment. Only 1 in 10 Americans with substance use disorders is able to access treatment, and of the few who receive treatment, few receive anything that approximates evidence-based care. Reimbursement is key to modernizing these services and ensuring that Americans struggling with addiction receive timely, appropriate, and evidence-based care. The Affordable Care Act, the mental health parity efforts go a long way toward accomplishing this, but requiring insurers to provide coverage for substance abuse treatment, but much more work remains. I know the states are experimenting with some innovative ideas. Dr. Wolk, can you provide us with an overview of Colorado's efforts to integrate behavioral health services into the primary care setting in the same Medicaid program?
Thank you, Representative Tonko. Yes, and it's actually not just for Medicaid. We have a goal that all payers in the state will evolve with payment reform models that will allow integrated behavioral and medical care to be provided at the site of primary care. Our goal over the course of the next 4 years is that 80% of all primary care practices in the state, whether they're federally qualified health centers, whether they're clinics, whether they're private practices, will all have some form of integrated behavioral health care as part of the primary care that's being provided as the patient's medical home.
And are there any federal policy changes that you would suggest are required in order for us to ensure integration is indeed successful?
Thank you, Representative Tonko. There are, along the lines again of really aligning the incentives to make sure that payers, for example, don't capitate or apportion behavioral health services and payment to a provider that's not part of this integrated model. It splits payment and therefore splits services, and so as a patient, you could come see your primary care provider, and that primary care provider would be prohibited from providing you mental health or substance abuse treatment services because the payer has allocated that money to a behavioral health care provider or substance abuse provider on a prepayment schedule, and that's where we could use some help with regard to reforming how those payments are made.
And Dr. Barrow, just quickly, what do you view as the main barrier to integration of behavioral health and physical health?
So I think the main barrier is stigma, and that stigma penetrates throughout our entire system. My time is up, so I'll stop there. If I can say one more thing, is that in Massachusetts, we too are looking towards outcome-based, value-based care throughout our system, which includes the real cornerstone being primary care and behavioral health integration at the office level. We have multiple pilots going on, including programs of prescribing Suboxone in our community health centers. Thank you.
Thank you. I yield back.
Thank you. Gentleman yields back. It's interesting the way to deal with stigma is straight on and integration. Good. Mr. Flores, you're recognized for 5 minutes.
My questions have more to do with the education elements of that. The reason for the background for this is that I have 3 major educational institutions in my district: Baylor, Texas A&M University and University of Texas, that have, that are associated with physician hospitals, medical schools. And so I'd like to drill into going further upstream, and that is, what can we do with the physician community, the expert community, professional community, to help them to be able to deal with this better? So my first question is this is for each of you. Should all physicians be required to complete a continuing medical education course on pain treatment? And if so, should they also be mandated to complete one on addiction? And I'll just start with you, Mr. Adams.
Should all physicians, I would say, I'd change that to say all prescribers.
Okay.
Because it's not just physicians prescribing, and not all physicians prescribe opioids. But we've had tremendous success, again, in Indiana. Once we instituted the opioid prescribing rules, then that led to an educational campaign where we had the opportunity and created the passion for these docs, and they had to carve out the time, these docs and other prescribers, to learn about the proper ways to prescribe.
Okay. Dr. Barrow, your thoughts?
So we also have all physicians required to do pain management training, but to your point, I would say that most medical schools, PA schools, nurse practitioner schools, et cetera, other practitioners who prescribe do not have required training on addiction, or its variable, in school.
Okay.
So going further upstream at a federal level, these accreditation bodies, it could be looked at to require some of that training.
Okay. Dr. Walk?
Thank you, Representative Flores. In Colorado, some of this training is tied to malpractice premium reduction, and so a way around making a
stick.
requirement is you can save some money on your malpractice insurance if you take this training. And as we said, don't forget about the dentists, the nursing community, the optometrists, and the podiatrists, because they're all prescribers, to the point that was made before.
Okay, great. Mr. Stringer?
And my answer to your question is unequivocally yes. There should be mandatory education training.
So the next question would be, and this is again for all of you, do you think your state, does your state think there's any merit to linking mandatory physician education for PDMPs to DEA licensure as a way to promote physician use of PDMPs when prescribing a controlled substance? Dr. Adams?
I've been long-winded before, so I'll be very brief. Yes.
Okay. Dr. Barrow?
We already require, at the time of license renewal, for all physicians to sign on to PDMP, and that's how we've increased up to 79%.
Question is yes on the merit. Okay.
Yes.
Great. Okay, perfect.
Yes, we already require.
Okay. Mr. Stringer?
Sadly, I can only speak theoretically or hypothetically, since Missouri is the only state in the country that does not have a PDMP yet, although we came very close this session. But
Okay.
so I would say yes, theoretically yes.
Okay, theoretically, I understand. Again, for each of you, and we've got just a minute 45 left, what are the opportunities to, or let me rephrase it, what are the opportunities to improve the education of physicians on the appropriate prescribing of prescription pain medication? Is it medical school, continuing education, all the above, or somewhere else?
It's both. I'm a assistant professor at the medical school, and we don't get it in medical school, but then there are docs out there who are prescribing or want to prescribe who don't have that education. And I'm sorry to keep bringing it back, but in many cases, the majority of the people doing the prescribing of opioids are not physicians. So you can do all you want with docs, but if you aren't taking care of everyone who's prescribing opioids, you're not going to solve the problem.
Okay.
I would say all prescribers at all levels, but also to bring back to the point that we all have to be educated, so it's a cultural shift also to our expectations of pain relief.
Okay. Dr. Walk?
I believe it is ongoing, but again, think about tying it to their wallet and their malpractice premiums.
Okay, Mr. Stringer?
All the above.
And the last question is this, and just a comment, you talked about, I think, Dr. Barrow, you said something about a cultural shift. Is this going to be hard to implement if we begin pressing all of the prescribers to have continuing education, and then further upstream to have the medical schools or the professional schools mandate this as part of their training? Do you see do you see pushback in doing
It's
this?
mandated right now in Massachusetts, and I believe the prescribers really want to be part of this solution, so they're looking to work together. So I think that will be the driving force. They're also fed up with the numbers and the statistics.
You'll see pushback, but it's something that we have to do. And again, as Dr. Burrell mentioned, docs want it, but we need to facilitate them getting the education and needing to carve out the time either via tying it to the wallet or tying it to certification.
Okay, thank you. I yield back the balance of my time.
Chairman yields back. Now recognize the gentlelady from New York, Ms. Clark, for 5 minutes.
Thank you, Mr. Chairman, and I thank our ranking member. I also thank our witnesses for lending your expertise to through your testimony here today. I'd like to ask about the impact of Medicaid expansion on increasing access to treatment for substance abuse disorders. According to the Centers for Medicare and Medicaid Services, an additional 11.7 million individuals were enrolled in Medicaid and CHIP programs since the initial marketplace enrollment began in October of 2013. However, 21 states have decided have failed to adopt the Medicaid expansion, leaving large coverage gaps for adults whose incomes are too high to qualify for Medicaid, but too low to qualify for premium tax credits through the exchanges. Let me start, Dr. Adams, by asking, has Medicaid expansion affected access to behavioral health services in the state of Indiana?
Well, the answer is yes, but I want to correct a term you used. In Indiana, we didn't expand Medicaid. We received a waiver to reform our Medicaid program via the Medicaid expansion funds. And I think that is a key here, that we need to allow states to come up with the best possible policy.
That wasn't my point.
Yes.
Just a question.
Yes, ma'am.
Has expansion impacted your ability to address the HIV outbreak in Scott County?
Expansion via the Healthy Indiana Plan has substantially increased our ability. We have we signed up over 300 people for health coverage as part of this outbreak into our Healthy Indiana Plan.
Well, I thank you for your illuminating response. I hope that other states recognize the impact that Medicaid expansion can have on their ability to diagnose and treat substance abuse disorders and comorbidities such as mental illness, HIV, and hepatitis C. Mr. Stringer, I'd like to turn to you. The current limit for non-disabled adults to qualify for Missouri's existing Medicaid program, MO HealthNet, is 18% of the poverty level, or $2,118 a year. Missouri is a state that has not expanded Medicaid, resulting in a large coverage gap of adults whose incomes are between 18 and 100% of the federal poverty level. Approximately, Mr. Stringer, approximately 300,000 working adults would gain access to health coverage through Medicaid expansion. Is that correct? Yes, that's correct. How would Medicaid expansion affect the population you serve in Missouri?
Well, ma'am, of those 300,000, we estimate that about 50,000 are people with some type of mental illness or substance use disorder that have no coverage at all right now. And so we are right now, for those that are in our system, we're paying for those with 100% general funds or block grant funds. If and when we expand Medicaid in Missouri, those people will receive Medicaid coverage. They will be, which does cover substance use disorder treatment in Missouri, and that would therefore free up those funds to treat people who remain uninsured for whatever reasons, to provide other kinds of services to help people get back to work, things like that. So it would have a tremendous impact in Missouri.
Wonderful. I thank you for your perspectives, and I yield back the balance of my time.
Gentlelady yields back. Now recognize Ms. Brooks for 5 minutes.
Thank you, Mr. Chairman. Dr. Adams, you recently wrote an op-ed, and your quote was that building a model for prevention and response should this type of outbreak happen in other communities in the U.S. Can you talk to us a little bit, and kind of trying to bring it back a bit to the HIV outbreak in Scott County? Can you explain for us what the model looks like? When you talk about the model, what model are you referring to?
Thank you for the opportunity. And the governor and I sat down at the beginning of this and said, we're going to make mistakes, but we want this to be a model moving forward. And one important part of that was a comprehensive program. The HIV spills over into the opioid epidemic, spills over into hepatitis, et cetera. And at our community outreach center in Scott County, we wanted to make sure patients were able, or people were able to access a multitude of services that are constant barriers to them getting into the treatment that they need. At our community outreach center, we've had over 789 visitors, 271 HIV tests, 302 people enrolled in the Healthy Indiana Plan, 87 mental health referrals, and 38 job referrals. And we also offer birth certificates and identification, which is a barrier for people signing up for insurance. And importantly, immunizations for hepatitis A, hepatitis B, and TDAP. When you include the needle exchange into that, I'd venture to say you won't find another place in our country that offers all those services under one small roof. Now, what we need to do is look at that as a success, and in terms of responding to an epidemic in the future, other places should consider providing all those comprehensive services. But for the long term, we need to make sure within communities, we're not just providing one part, that we're providing the comprehensive services people need, because, again, this is a vulnerable population. Okay, here's health insurance. Well, I don't have an ID to sign up for it. I can't prove I'm a citizen. Here's access to HIV care, but I don't have transportation or it's not available. There's an opportunity for you to get into a treatment center, but the people aren't here, they're not close by. So when I say a comprehensive response and a model response, it's including all those services and thinking about overcoming barriers for the people we're trying to reach.
Thank you very much, and best of luck as you continue to lead the efforts on behalf of the state. I want to shift very briefly in the time I have left to discussion about the criminal justice system. And in a previous hearing, we talked about drug treatment courts, and obviously the state also has a tremendous responsibility for the correction system, and the correction systems are administered by the state. And so I'd be interested in any of your comments with respect to what your states are doing with respect to opioid abuse in our correction systems and/or the coordination with the drug treatment courts. I know that's a big question, but yet I think that is a group of folks who are incarcerated or who are on their way to incarceration through drug treatment courts, and I'm really curious what your thoughts have been in your states.
Briefly, in our district, we've had much success with Vivitrol and drug courts and diversion programs, and we've actually connected the prosecutors from Hamilton County, which is in our district, with the people from Scott County to share best practices, and I think that's going to be a critical aspect moving forward to empowering people when they're in, quite frankly, when they're a captive audience.
Thank you. Dr. Walker, Mr. Stringer?
I talked earlier about a project we have going on in Missouri within our Department of Corrections where people are started on medications before they leave prison. That's happening in several of our institutions right now, as well as the St. Louis City jail before people go into drug court. So we're starting people on medications before they leave incarceration. We also have a growing number of drug courts in Missouri, all of whom have embraced medication-assisted treatment. In fact, the drug court contracts in Missouri require that drug courts offer medication-assisted treatment for people for whom it's appropriate.
Dr. Walk, anything with respect to Colorado's approach?
Thank you, Representative Brooks. It varies by where the population is most dense. So we have a very active program in the Denver metropolitan area, a variety of treatment options and transition programs from corrections back into the community as well. It's not as easy to take advantage of those in the more rural parts of our state.
Thank you. Dr. Burrell?
And in Massachusetts, we have a strong support for drug courts, diversion programs, and starting medication-assisted therapy. And part of our working group includes law enforcement and multiple segments of the community. And in addition, we have several pilots going on where before release, individuals are connected to community health centers so that their continuity of care can happen in both behavioral and medical illness.
Thank you all for your work. I yield back.
Mr. Green, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I'd like to focus on questions on the overprescribing of opioid pain relievers and what states are doing to prevent the opioid addiction in the first place. CDC Director Tom Frieden quotes, overdose rates are higher where opioid painkillers are prescribed more frequently. States and practices where prescribing rates are highest need to take a particularly hard look at ways to reduce the inappropriate prescription of these dangerous drugs. As this quote says, the states where the rubber really meets the road in terms of prevention efforts and addressing the overprescribing opioid. Dr. Adams, I know Indiana has been hit hard by the opioid abuse epidemic. Can you tell us what the mandatory prescription guidelines that the Indiana Medical Licensing Board develops? And not just the Medical Licensing Board, if you could talk about all the practitioners, nurses and dentists that have the same, hopefully the prescribing requirements are on all the specialties.
Thank you for the opportunity. And we passed those rules, and the Medical Licensing Board passed them initially for physicians, and now the other boards are adopting their own versions of the rules. But again, a critical part of that was the mandatory checking in and being a part of the INSPEC, the Prescription Drug Monitoring Program, a mandatory part was assessment and H&P and regular visits. You've got to have a face-to-face and a relationship with a patient before you prescribe. A mandatory part of that is drug testing, so we can know what you're taking and if you're taking it appropriately. And as many people will take more, there are frequently people who are diverting. And we found that problem in Scott County. Again, a lot of the prescriptions are to little old ladies who really do have chronic pain issues, but they can resell their pills for $500, $1,000 and quite frankly put diapers on their grandchildren versus properly use those opioids. So we need to be able to drug test people who we're giving opioids to, and we need to have contracts. Again, the docs have told me that they're scared to write, and then the docs that are writing are scared not to write because you can get sued either way. And so we need to be able to protect docs and their ability to do the right thing.
Okay. Do you believe efforts are making an impact on inappropriate prescribing of the opioid medications? I know you said the other specialties, but at least on the medical board that you may have some evidence on?
Well, exactly. We've seen drops of 10% in prescribing since we adopted the rules. We have a lot fewer pill mills, and that's really what was the impetus for this. But we've got to do a better job with our prescription drug monitoring programs. Best practices need to be adopted, and the ability to communicate across state lines, however we facilitate that. Because we can't do anything if we don't know the numbers, and we can't do anything if we know the numbers, but we can't share the data with the appropriate prescribers.
What should we be doing on the federal level to support your efforts implementing effective interventions to prevent opioid abuse?
Well, Senator Donnelly and Senator Ayotte have a bipartisan bill that they are promoting right now that has a lot of good ideas in it, and I would encourage you all to look at that rather than me spend time going through each of the points. The Heroin and Prescription Opioid Abuse Prevention, Education, and Enforcement Act of 2015. I think it's got a lot of the right ingredients in terms of task forces and highlighting the areas that we need to concentrate on.
Dr. Walk, can you tell us about some of the same in Colorado, the opioid prescribing guidelines developed by the state boards, again, whether it's medicine, pharmacy, nursing, or dentistry?
Thank you, Representative Green. Yeah, it really just keeps coming back from the provider perspective to the two main points, or the two number one priorities. One is the mandatory participation in PDMP registration, and the second is some form of required or strongly encouraged training with widespread adoption across all the disciplines. Because we've seen, like I said, 87% of those who participate in the training said that they would change their practice as a result of it.
Okay, I only have a few seconds. One of the issues is doctor shopping, and is there anything technologically we can do to deal with that?
Yes.
And this would be all for all the...
Sure. We've had a lot of success with the use of our health information exchange and having broad participation by all of our hospital systems in the state of Colorado, and now well over 1,000 providers who have connected their electronic health records to each other, so that when somebody comes into an office or an emergency room, it's relatively easy to now see who they've seen and what they've been prescribed or provided for.
Mr. Chairman, in my last second, Dr. Burwell, you talked a lot about federally qualified health centers and the community centers. Or in Massachusetts, they have access to that same medical record across the lines of the different centers?
Yes, so there's many different integrated health records that we're looking at, and the PMP is really adding to this because it's system-wide. Any prescription written within Massachusetts or written out of Massachusetts for somebody residing in Massachusetts, what we really do need, though, is interoperability that's better between states and also between different EHRs, so we can then expand our view.
Okay, thank you, Mr. Chairman.
Thank you. Gentleman from Oklahoma, Mr. Mullins, recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you for being persistent on getting down to the roots of the problem. I mean, this is obviously an epidemic, and I'd say most of us know somebody that has abused prescription drugs at one time or the next. Yeah, you know, recently I just went through a surgery on my elbow and got prescribed a big old pill of pain medicine, and I wouldn't even take one of them. Fortunately, I've had a lot of surgeries, or unfortunately, and I've built up some type of a pain tolerance, but it does become a habit. The pain's still there, it just masks it. And when you get used to it, it becomes a dependency. And what we're seeing is, in my opinion, it's severely being just prescribed. And Dr. Burrell, you're aware of the severe rise in methadone prescriptions, I'm assuming, right? The rise in it, how often it's being described?
The rise in methadone, yes.
Right.
Yes.
Are you aware that methadone accounts for 30% of overdose deaths, while only basically covering 2% of the prescriptions?
Yes.
Then I guess the question is why does Massachusetts leave it as a preferred list as a drug to be prescribed when CDC is saying it shouldn't be the first line? It should be considered just in a case-by-case situation rather than being prescribed on a regular basis.
Thanks for your question. So methadone, has become a part of the armamentarium of what can be used as pain relievers. In looking at our data within Massachusetts and the data that we collect at the Department of Public Health, when we collect preferred drug of choice first and second, methadone is actually lower than the average in Massachusetts. It's less than 15% is the preferred drug of choice. But just like with all the other medications, there needs to be education around how to use methadone, if it is going to be used for pain or not. So I agree with that point. You brought up a point earlier about many people knowing somebody who has used or abused opiates, and I want to bring up a point. There was a recent study done through the Harvard School of Public Health where they looked at the majority of us know somebody who has struggled with addiction, and of those who have, 20% of us know somebody who's died from it, so it's really a profound problem, to your point. And one very interesting thing related to this question that you're asking is that 36% of individuals who were prescribed an opiate were not made aware or did not know about the addictive potential. So I think that needs to be part of the education.
Then, and I agree with that, but then if we know that and it's so readily accessible still yet, I'm concerned why Massachusetts and Indiana, Dr. Adams, would still leave it on your list of prescribed medications. I mean, when CDC and American Academy of Pain Medicine both have said that methadone should not be considered a drug of first choice. But when it's listed, we all know that doctors refer to this constantly. In fact, that's where Medicaid and Medicare a lot of times gets the prescriptions or the drugs that they're able to prescribe from.
It's cheap.
Well, so a person's I know, but so a person's life is cheap?
Well, no, a person's life is not cheap, and I appreciate that question. Again, as a person who's been trained in pain management, methadone is a great drug when used appropriately. So the problem is that the prescribers aren't educated and aren't using it appropriately. So you've got a policy situation where you have a cheap drug that the doctors know can be used appropriately, but a real-world situation where it's not being used appropriately.
Dr. Adams, I really appreciate your bluntness. But cheap shouldn't matter when we're talking about someone's life. We know it's being abused. History says it's being abused. So why is it still there?
Well, because again, from a policy point of view, there's two different directions you can take this. You can either say, take it off the formulary, and what are we going to replace
Education
it with?
isn't working. We all get those little bottles with a little label on it, and then it's even got a folded up package. And I'm sure everybody in this room's always read that folded up package. And all of us know what the side effects are and what the consequences are of everything that we've ever taken. And in fact, if you're one of those people, I'm not.
And as the state health commissioner, I will tell you, you're right. And again, I'll be blunt and say you're right. There is a problem, and we need to figure out the best way to address the problem while still providing pain management options for the people who are out there.
So, Dr. Adams and Dr. Burrell, while we're figuring it out, do you still think it's a good idea to have it on your website as a preferred medication?
That's a great question, and again, the blunt answer is that's a different division than my division. I've spoken with Dr. Werner about this problem, and docs feel passionately on both sides of the issue, but it is at the top of our radar in terms of making sure we're educating people and considering all options.
Dr. Burrow, you want to follow up on that?
Gentlemen's time's expired. If you can do it real quickly, we're about to have votes, so I want to move.
I think this issue is going to be a multi-pronged approach, and one of them is looking carefully at the medications we prescribe and making sure that individuals are educated on how to best prescribe them. Thank you for your question.
Mr. Chairman, thank you.
Thank you. I recognize now Dr. Burgess for 5 minutes.
Thank you, Mr. Chairman. And I must say, every time I listen to the gentleman from Oklahoma, I learn something, and there's a hazard in relying on a medical education that's over 40 years old. But I remember the morning in medical school hearing the lecture on methadone, and it was repeated over and over again. Methadone is for maintenance purposes only. I mean, I'll never forget the guy saying that. But is that no longer true? Methadone now is being used for things other than maintenance? Dr. Adams?
In terms of maintenance for medication-assisted treatment, or you mean for chronic pain?
For someone who has an opiate habituation.
Well, the answer is that there are a lot of prescribers out there who don't have the proper education to be prescribing the drugs that they are prescribing, and it is a problem.
But again, 40-year-old wisdom, you have somebody who has a narcotics habit. They want to rehabilitate themselves. They want to get back to taking care of their family, back into society. They can be maintained on methadone.
Yes.
And allowed to function because it didn't have the other effects that other opiates do, so they didn't get the high. But they solved the problem of the addiction, at least temporarily. But now methadone is used has uses beyond that.
Well, okay, so I'm glad you brought that up. Again, there's a lot of misunderstanding about methadone. There's methadone as used for chronic pain, which the gentleman from Oklahoma was talking about, and then there's methadone for medication-assisted treatment, which is the person who has substance use disorder who's using it to continue functioning. Those are two very different uses of methadone, and confusion has led to a lot of policy decisions that I think are under-informed. It's important to know that methadone can be a substantial and important part of people's recovery if they are suffering from substance use disorder, but it's also important, to the point of the gentleman from Oklahoma, that we recognize and deal with the real problem of methadone being prescribed for chronic pain inappropriately because it's killing people. I completely agree with you, and I thank you for bringing up that point, sir.
All right, I'm going to switch gears because I had a couple of questions about naloxone, and I've got some other questions about NASPR that I'll probably have to submit for written responses because of time. But on the, we've had a number of these hearings, and I've expressed support for having compounds like naloxone or Narcan available over the counter. I mean, let's be honest. People need it. They need it right now. They don't need to be going to get a prescription. So just this week, the FDA announced a public meeting to discuss increasing the use of naloxone. Now, Dr. Burrell, in Massachusetts, your state has been kind of an early adopter in this area. Can you share some of that experience with us?
Sure. So as I mentioned earlier, we've been using Narcan treatment since 2007. We first started by doing outreach to high-risk individuals who are using injection drugs as part of an actually HIV prevention treatment education program. And since then, from there, moved on to work with so-called bystanders, which are family and friends. And we use our existing community coalitions, such as our Learn to Cope family-run coalitions throughout the state, in order to have them provide Narcan. And this is done through standing medical orders. So it's still not an over-the-counter, it's through standing medical orders, as well as certain pharmacies participate in having it available through standing medical orders. And then finally, through the first responders program, both fire and police in dozens of communities across Massachusetts have adopted the program as well.
And Dr. Adams, can you share with us some of your experience in Indiana?
Well, we've had great success, some wonderful stories, but I want to second a point that Dr. Burrell made earlier, that it's important not just to hand out naloxone, but to provide education as part of that process. There is a big fear and I think Representative Murphy brought this up earlier, Chairman Murphy, that if you're giving people this, they will then use it as an excuse to abuse. That's been proven not to be the case when you combine the passing out of naloxone with education. So when you're considering policies moving forward, please don't forget the educational component, because that's what saves lives along with the naloxone.
Yeah, of course, that can be said about so many other things that we sometimes get involved in. But I appreciate your answers, Mr. Chairman. I'm going to yield back time because I know votes are coming.
All right, I want to thank all of the members who were for this, and this panel. This has been a fascinating process. We know that what will come out of this. We'll get our staffs together with it. You gave us a great set of recommendations. Say thank you. We do ask you to follow up on some of those other questions, and please feel free, if you have other thoughts that come from this, it's kind of things you're thinking about on the plane ride back or when you get back to your colleagues. We want to see what we need to do in terms of drafting legislation, working with the administration on regulatory changes, working with associations on some of these issues. This is critically important. Too many people have died even during the course of this hearing today. I know you all care deeply about this. We share that caring, and we want to see this change. So thank you very, very much. So I want to thank all the witnesses and members again for being here, and remind members that they have 10 business days to submit other questions to the record, and we ask that you respond promptly to that. And with this, this committee hearing is adjourned.